My name is Sarah Broderson. I will be presenting over nursing theorist Catherine Kolkaba and her nursing theory, the comfort theory. This presentation is from Mount Mercy University related to Research 1. The objectives related to this presentation are comfort theory overview, overview of the theoretical model, identify concepts of comfort theory, and explain the comfort theory as used in current practices and research. Catherine Kolkaba was born and raised in Cleveland, Ohio. From there, she graduated from St. Luke's Hospital School of Nursing in 1965 and went on to work in gerontology and end of life areas of nursing. She also went on to get her PhD in the 1990s and became known for her contribution to nursing research and nursing practice. Catherine Kolkaba specialized in multiple areas, including gerontology, end of life, long term care, comfort studies, nursing theory, and nursing research. She went on to publish Comfort Theory and Practice, a vision for holistic healthcare and research in the 1990s, along with her PhD. Currently, she works as a professor at the University of Yukon College of Nursing. Catherine was a huge believer in holistic nursing. She saw nursing and comfort cares as an art, she described it as. She believed that comfort care was a need for every human being, and nurses and healthcare providers needed to intervene and find the variables that were causing discomfort. The comfort theory is seen as a middle range theory as it has specific ideas, but is also related to limited concepts and low abstraction. It is also a conceptual framework as it has multiple contexts and multiple ideas that are organized well. This theory was organized to improve patient outcomes, identify variables related to discomfort, improve nursing relationships with both patients and families, improve satisfaction, and improve the quality of life for patients. The word comfort is a broad idea. As nurses, we know we want to make our patients comfortable, and to be able to do that, we have to identify how to improve their comfort. Catherine was able to identify 3 forms of comfort. 1 is relief, 2 is ease, and 3 is transcendence. These 3 main forms of comfort will help us identify how to improve comfort for patients. The first form of comfort is relief. This defines when I think of comfort, I think of the physical being of a patient. Relief defines the comfort needs are met by a patient, and that will cause a sense of relief for that patient. When I think of comfort in general, I think of a patient uncomfortable or in pain, and how we're actually going to improve that to make that patient comfortable. For my example here, a patient's painful, so a nurse is going to intervene and give pain medications. That patient, after that pain medication is in full force, they're going to have a sense of relief as they're less painful. The second form of comfort identified by Catherine is ease. Ease is defined as contentment or the sense of being calm, even. My example here is a patient is very anxious. Someone has addressed this and has intervened in some way, and the patient is able to have a calming sensation or ease. The third form of comfort is transcendence. Transcendence is defined as rising above challenges or being able to recover. My example for this is a patient is able to graduate from physical therapy after some sort of injury. Transcendence is the ability to have a comfort in that they are overcoming something. Along with the forms of comfort, we also have contexts related to comfort that Catherine has identified. The first one is physical. Physical is related to like the physical body sensations, pain, mechanisms of the body. Usually this is related to the form of comfort as relief. The physical, for example, is again that pain medication, that physical sensation of pain has been overcome by that pain medication, and that patient's going to have relief. Psychospiritual is defined as self-esteem, identity, sexuality, meaning in life, and a person's spirituality even. This is usually seen as the form of comfort of ease. Environmental is temperature, physical surroundings, noise, smells, etc. That can cause comfort or discomfort for a patient. Usually this will be seen as also relief as a form. Sociocultural is family, social relationships, religious practices, and traditions, etc. This can also be seen as ease as well by making a patient comfortable in that form. The visual shown gives a really good example of being able to identify variables that may be causing a patient discomfort or an area that the patient's comfort could be improved in. For example, your contexts are on the sides and your forms of comfort are up top in the blue. For physical, and relief, there is nausea listed, for example. If a patient was experiencing nausea, we could easily intervene with an antiemetic medication. By giving this medication, we would be intervening on that variable that's causing that patient discomfort and end up causing more comfort for that patient in the sense of relief. The comfort theory model shown here on the left-hand side shows that healthcare care provider identifies that there is a need of some sort for a patient or family member. That healthcare provider then can go into identifying an intervention that may be needed to intervene on that variable. This then turns into an enhanced comfort of some sort, if that's relief, ease, or transcendence. This also goes into show that when a patient has enhanced comfort, they have better health-seeking behaviors, which turns into, especially with like a hospice patient, a more peaceful death. Or if we are causing comfort in another way, they have more internal behaviors related to comfort and external behaviors. This can also help us to identify best practice and best policies to intervene on comfort. Now that we have gone over the comfort theory, who is actually influenced by this theory? Fortunately, this theory is actually related to daily practice of every single nurse and every single healthcare provider. It is used in everyday care as nurses are taught to identify problems, be that an assessment or emotional distress for a patient, and they are taught to identify interventions that can help improve or get rid of that variable that's going on that's causing that patient discomfort. Nurses strive to comfort patients, and that's honestly why we became nurses. We want to intervene and make those patients comfortable. It is also shown in our care plans as well, as we are able to identify problems, cause an intervention of some sort to improve that assessment that we may have found or some kind of discomfort that that patient is having at the moment. And then we're able to evaluate that over time as well and set goals. The comfort theory is actually used within multiple areas of nursing. As comfort is required within every single department. It's been used in studies in NICUs, labor and delivery, cardiac, transport, hospice, etc. Many guidelines and clinical practices have actually evolved related to the the comfort theory and have been based around this theory in evidence-based practice.